Okay, so maybe let's start the session for today. So hi everyone once again, and welcome to the fifth session of Respect and Shame and Healthcare and Bioethics workshop series. And I'm really thrilled and looking forward to continue our discussion around the key things which we are continuing. This is our fifth session, so I'm pretty excited about that. So this is jointly organized by myself. I'm Supriya Subramani. I'm a postdoctoral fellow at the Institute of Biomedical Ethics and History of Medicine at University of Zurich. And Professor Luna Dolezal, unfortunately, she couldn't join us today. And she's an associate professor in philosophy and medical humanities at University of Exeter. So this workshop is funded by Wellcome Trust Shame and Medicine Project. So what we are trying to achieve in this workshop series is we are trying to critically engage with both the conceptual, philosophical, and as well as phenomenological understandings of respect, disrespect, and shame and related self-conscious emotions. So by bringing together different scholars from different disciplines and who uses a different frameworks, we are trying to enhance the much rich debates which each interdisciplinary works will provide to understand these concepts, and also goes back with the bioethics debates, how this can be much helpful for the bioethics disciplines in itself. So before moving to our first talk by Peter Schaber, just a bit of housekeeping information we have. So the workshop will be recorded and the copy of it will be sent to you all. And also it has been uploaded on YouTube on all our earlier recordings. So please feel free to look at that. And as well as we have it on the Shame and Medicine project. So the format of this session is that first speaker will be giving for 40 minutes, 30 to 40 minutes of presentation, which will be followed by 20 minutes of open discussion. And then the second speaker will give a talk for 30 to 40 minutes. And then Peter would be giving feedback, like targeted, feedback of the paper or by Katharine. And then there will be an open discussion. So that's the format for today. And if you have any questions or want to have a comments, please use the chat box, or also feel free to raise your hand. And on the final note, there will be a special issue in the Journal for Evaluation of Clinical Practice, which is arising out of this workshop series, which we are very happy about. And we have opened the call for submissions. And please find the CFP on the chat box too. And so, yeah, if you're working on these concepts, we look forward to your submissions there. So today, Peter Schaber will be presenting the paper Respect for the Patient's Will. Peter is a professor for applied ethics at the Center for Ethics, University of Zurich. He was previously lecturer at the University of Göttingen and Hanover. He is a co-editor of the Routledge Handbook, The Ethics of Consent, and the member of Executive Board of the Society for Applied Philosophy. And I'm quite thrilled that he's here, and I'm so happy that he accepted this invitation. I'm really looking forward to your presentation, Peter. Over to you.
Thank you very much, Supriya, and thanks very much for the invitation. It's a great pleasure for me to be here. And let me share the presentation. Is that okay? Yeah. Right, lovely. So I will talk about the concept of respect, namely respect for the patient's will. I renamed the presentation. It was before the patient's wishes, and it's basically not a substantial difference. What I mean by wishes and by will in this context is simply what patients want with regard to medical treatment. So if they want the physician to act in a certain way. So that's what is meant, and it can be called wishes, and it might be a little bit stronger. It might have more normative meaning if you call it will. The presentation has three parts, and I will start with compliance and consideration respect. That is, I will start with a distinction that has been made by the philosopher Suzanne Uniacke, and this is the distinction which is related to the principle, the famous principle, namely the principle for to respect the autonomy of the patient. It's a well-known principle, and it's one of the basic principles, not the only one in medical ethics, but it's definitely one of the basic principles, probably not just in medical ethics, but also beyond. And there is a standard interpretation of this principle, what it means to respect the autonomy of the patient. And the standard interpretation, which is defended by various authors, for instance, by Honora O'Neill, the famous British philosopher, is what might be called a minimalist version. And the minimalist version tells you that patients should not be treated against their will. So if they, if you offer a certain treatment to a patient and the patient refuses to undergo the treatment, says no, and doesn't, of course, as a consequence of his or her negative will, not sign the consent form, the physician is not allowed to undertake the treatment. So that's the respect for an autonomous will, given, of course, that the refusal is an autonomous refusal and is an expression of an autonomous will. It tells you not to treat patients against their will and without their consent. And it's also sometimes called, for that reason, because it's just a negative version, or it's also called minimalist version, a non-coercion principle. So it's what you're not allowed to do as a physician is not to coerce patients into treatment. And the questions that has been discussed, and it's of course a relevant question, is this all what respect for autonomy principle requires, namely to respect the negative will of patients? It could be, and that's the topic of this talk, it could be that autonomy has to be taken in a wider sense, not just in this negative sense, respecting the patient's will, do what she wants the physician to do, respecting the negative will, just comply with her negative will, what she refuses as a treatment, but it could also include respecting the patient's will, do what she wants the physician to do, and not just what the physician takes to be in the best interest of the patient. And the question is, I want to ask, should we take autonomy with regard to the famous autonomy principle in this wider sense, and should we include, and how should we include the patient's will, not just the negative, but the positive will, as you might call it. Now, talking of respect and respecting the will or respecting wishes, a distinction has to be made, namely a distinction between two senses of respect for a patient's will. Before we start the discussion, before I discuss the question I just raised, namely, and that's a distinction made by Suzanne Uniacke, I think it's a very helpful distinction, namely compliance respect and consideration respect. What is compliance respect? Compliance respect means if compliance respect is required, then the will of the patient is binding for the physician. I mean, that's a general issue. Compliance respect means the will of another person, if the object of what is to be respected is a will, is binding. So, for instance, in the negative case, if the patient doesn't want to undergo the treatment, this is binding. That's the final word. There is no discussion required anymore. The negative will has to be respected, period. So on the standard view, compliance respect is required regard to what people don't want. Then consideration respect is something different, something probably weaker. Namely, consideration respect is required and means that the will of the patient is not binding. That's the difference. That's how it differs from compliance respect, but rather is a pro tanto reason for the physician. Now, that's a philosophical term, of course. Pro tanto reason means if the will is something that speaks in favor of what is wanted. So if a patient wants a certain treatment, then you could say the physician has a reason amongst other reasons, of course, that speaks, if consideration respect is required, that speaks in favor of the treatment. So the negative will or the positive will, whatever, in the consideration respect case, if consideration respect is required, is not binding, but rather providing reason. So it has a normative force, but a much weaker normative force. Let me explain a little bit the idea of consideration respect, because that's new. Because the standard discussion is led in terms of compliance respect. People think up till now, up till the distinction was made by Suzanne Uniacke, that we talk about respect in a sense of compliance respect, that the will is binding. And in the negative scenario, in the refusal case, the negative will of the patient is indeed binding. There's nothing to be considered and to be weighed against other things. Now, what exactly does consideration and respect mean? Here is the proposal made by Suzanne Uniacke, the paper I referred to. Quote, the first way involves the doctor assessing the patient's wishes entirely on their own merits. So to speak, here the doctor makes an independent judgment about the reasons and the values on which the patient's wishes are based. The second way of actually receiving consideration and respect involves the doctor giving the patient's wishes weight or purchase in her own deliberations as the patient's wishes, in addition to her independent evaluation of the reasons and priorities on which they are based. Let me explain a little bit, might be a little bit complicated. She makes a distinction between two kinds of pro tanto reason, namely the pro tanto reasons provided by the patient's will are reasons for the physician, or might be reasons for the physicians to check whether the will is really based on reason. So it's a philosophical way of putting the idea that a patient's will might be a reason to check whether it's really in the interest what the patient wants. I mean, as medical treatment. So, and the second, and that's the interesting sense of pro tanto reason, is the one that has to do with reasons for action. The patient's will provides the physician with pro tanto reasons for action. So just the fact that the patient has a certain will, wants to have a certain treatment, is a reason to undertake it. So that's the understanding of consideration, respect, and reasons. Consideration of respect is due to certain reasons provided by the will, and now not just epistemic reasons to check whether what is wanted is in the interest of the patient, but rather, and that's more important, to take it as a reason amongst other reasons, speaking in favor of doing it. Okay, now I was talking about the extension at the beginning, that probably the principle of respect to respect the patient's autonomy should be extended. In what way? Well, we've got the negative part. There's a standard on the standard view. There is agreement. Physicians have to respect the patient's negative will. As I said, refusals to consent, or just not having the will to undergo certain treatment. Now, the extension would consist in picking on Suzanne Uniacke's proposal that physicians should also respect the patient's positive will. Now, as I said, what the respect in the second sense could mean, it could mean two different things, either in the way that the patient's positive will is binding, that would be the stronger interpretation, or the weaker interpretation that the positive will of a patient is providing the physician with reasons, speaking in favor of the treatment. On Uniacke's view, the patient's will should receive consideration and respect. That means their will provides the physician with pro tanto reasons for action. That's her view. Consideration respect, again, that's her view. So if she's right, the following would hold. If a patient wants treatment X, the physician has a pro tanto reason to undertake the treatment X. Pro tanto reasons are to be weighed, and that's important, are to be weighed against the other reasons that are in play, reasons that are provided by, for instance, what the physician takes to be the patient's interests. But the important thing is that the patient's will, because it is the patient's will, that's important about the idea, not because the physician comes to the conclusion that it fits a certain interest, but just simply because she wants to have it, is seen in this model of respect as a reason to do it. As a reason, of course, a reason that might be outweighed and defeated by other reasons that are based on the patient's interest, or at least on the interests the way they're understood by the physician. Now, this would be an extension of the standard interpretation of the principle to respect autonomy. Why? Because the standard principle tells you, as I said at the beginning, we have to respect, or physicians have to respect, the negative will, and the rest is just up to how they see the interests of the patient. And the reasons provided are not provided by the patient's will. That's the standard understanding, but they are provided by the patient's interests. seen and interpreted by the physician. So if the physician comes to the conclusion that the treatment that is requested by a patient, or a patient wants to be undertaken, is indeed in the interest of the patient, then the standard view would say he has, or she, the physician, has a reason to do it, but only because she comes to the conclusion that it is indeed based on the interest. Now, the models would say we have to add something, namely the autonomous perspective, so to speak, of the patient, the view she has of her situation and what should be done. And then, of course, there would be a further extension if we would include compliance respect. Then, because as I explained, the patient's will is binding for the physician if we go for the compliance respect. Uniacke thinks only we should the principle of autonomy, respect for autonomy, should be extended only in this weaker sense, namely in the sense of consideration respect. The will should be taken as reason given. I think that both forms of respect for the patient's will may be required. Sometimes that's the argument or the idea. Sometimes I guess consideration respect is required, or only consideration respect is required. Sometimes even compliance respect. I want to, that's the idea I want to explain in the following minutes. Take an example, might help to get back to an example. This is also an example given by Suzanne Uniacke herself. I thought it might be helpful. So imagine Mrs. D's request for treatment that aims to relieve some of the symptoms of endometriosis might well be a mistake. That's the physician's perspective. Might well be a mistake, but the doctor can recognize that it is based on the patient's reason, and that it can be appropriate to take this into account in deciding for how long to persevere with drug treatment, or what point to call a halt to conservative surgery. Appropriate consideration and respect for a patient's wishes in relation to the provision of treatment can significantly influence both the way in which and also the extent to which a doctor discharges her duty of care. Summarize this example. So we have a certain assessment that the treatment the patients want to have that aims at relieving some of the symptoms of the disease, that might be a mistake. So the physician thinks it might not be in the interest of the patient, but it's actually recognized that it is based on the patient's reasons. So it's not his or her reasons. It's not that he thinks there are objective reasons to do so, but he can recognize that she has reasons to come to that conclusion, that she has reasons to have this wish. Now, what has to be done is, the standard view would say, when it comes to the decision, what should we do? What should the physician do? You could just say, well, you have to check what is really in the best interest of the patient, of Ms. D. And if you come to the conclusion that it would be in her best interest not to go for that treatment she wants to go for, then you should refuse, right? Despite the fact that she might have her reasons that you do otherwise. So, and leaving the standard model, saying now we have to take her point of view, her values, her reasons seriously, might make, as she states, as Uniacke states, might make a huge difference. So to make that point clear, to clarify that, reasons that are provided by the patient's will are those the physician refers to when she says, I do X because this is what she wants me to do, right? So it is not something that should be done. Then it's not a reason of autonomy, and that's not, then it's not based on purely on someone's wishes or someone's will. It is only based on someone's will, or the patient's will, to be more precise, if it is a reason for action, even though it's not seen as an objective reason for action from the physician's point of view. So like saying, well, she wants to have this pain relief. I think it's a mistake, but the fact that she wants it provides me with a reason I have to consider. That would be the model that would be the first extension, and the extension in the sense of a consideration respect, including the will as reason giving, right? The question is, of course, is that the case? Does the patient's will create pro tanto reason, or are they in certain cases even binding? Or is the will even binding? Okay, now, as I said, I think we have to go even further than Uniacke think. We have to extend it in two ways, in the consideration respect way, and as well as in the compliance respect way. Depends on the case, of course. Sometimes consideration respect is required, sometimes compliance respect. But first of all, let's come back to the negative interpretation. It is clear, if the patient does not want to be treated in a certain way, the treatment is impermissible. That's the non-coercion interpretation of the autonomy principle. Now, one has to be careful with the extension strategy, because one thing is clear: there is an asymmetry between the patient's negative and the patient's positive will. Her positive will is not binding in the way the negative will is, right? So the extension, what is excluded, I guess, right from the start, is an extension of the kind: what holds for the negative will is binding, also holds for the positive will. And there are reasons why this asymmetry is the case. And that's something to be explained. The asymmetry consists in the following: I have full normative control over my body, what others are allowed to do with my body. And that, of course, applies also to the physician. Now, and that's the asymmetry, I have no, or at least limited normative control over others in the binding sense. My positive will is not binding for others in the way my negative will is. Why? I think my normative power over my body, which explains the negative part of the interpretation of respect for autonomy, serves the control interest I have over my own body. It's good for us to be able to have normative control over our bodies. And because that's the case, we should control completely what others are allowed to do with us. And that includes, of course, also what the physicians are allowed to do so. And that's the justification for the negative interpretation of the principle respect to the principle of the respect principle for autonomy. Now, why is this asymmetry? It would not be good for us if we had, that's, I guess, the explanation. It would not be good for us if we had full normative control over each other, right? So the explanation is there is an asymmetry because it would be good for all of us to have full control, negative control, over what others do to us, but not what we can do with others. Why? It would not be good to have full normative control over each other due to following reasons. First, the costs of doing what others want us to do. That would be one reason speaking against such an extension, and that we have to do things we consider to be wrong. The normative control over my body protects, on the other hand, my sovereignty against others. It allows me to set moral limits for what others are allowed to do to me, serving a control interest. The positive will would, on the other hand, not just protect me from being treated in disrespectful ways and in other ways that would wrong me, but of course would also impose costs on others. And we, all of us, none of us is interested in having such a principle. So that's why there is at least only a limited normative control of others because of the burden it imposes on others. So we would not be interested to live in a society, we would not agree to a principle allowing us actually to impose these costs. And the second point, it would force others to do what they consider to be wrong. However, having said that, this is an explanation of the asymmetry, and I think it's an important point, why the negative will is much more important, from normative point of view, than the positive will when it comes to the normative force these two wills have on others. As I said, it would be completely implausible to have the same an asymmetry between negative and positive will due to the reasons just mentioned here, A and B. We wouldn't want to live in such a society, and we wouldn't live together with others in this way due to these two reasons. However, this doesn't imply that their will has no normative force for others. Why? It has a normative force. Your will has a normative force for others, depends on how costly it is for the other person and also on the relationship you have with them. Let me explain. Your will has a normative force for others if the costs for them, the others, complying with your will are very low. The costs one may impose on a physician are arguably higher than the costs you're allowed to impose on others. Why? Because there is a service relationship. So what the normative force of your will is, depends on the costs in general. That's a general point. And then, of course, also on the kind of relationship you have with the other person. That applied to the physician-patient case means the patient's will is binding. A, if the costs for the physician are low, that's also taken from the general point. And secondly, if there are no important reasons not to comply with the patient. The patient's will is binding because it would be good for us if physicians did what we want them to do, provided that neither A nor B or 1 or 2 is the case, right? So why should, put it that way, why should our will have a normative force on others? Because it would be good for all of us if that was the case. But of course, it would not be good if it was in the same way the case as it is in with regard to the negative will, namely because due to the costs it would impose on each of us. Now, what the costs are we might impose on others depends, as I said, first of all, on how heavy the costs are, how high the costs are, and then, of course, it depends also on the kind of relationship we have. And that matters to the physician-patient case because, or to the physician-patient relationship, because simply I take this to be a service relationship. And that has the consequence that the costs we might impose on others are higher than in relationships that are not service relationships. Okay, if the costs are higher, the patient's will is not binding. Simply due to the principle, it would not be good for us if that was the case, right? But it does still provide the physician with reason for action. The patient's will is reason providing means that it has to be weighed against all other reasons, speaking in favor of and against the treatment. That was the point about considerations respect. So if the costs are higher, if the costs are very low for the physician, I take it that the patient's will is indeed binding. So for instance, take a case where someone wants to be treated on a Thursday, and there is no reason speaking against that. There are no costs created by this will, actually by complying with this will. It would be easy to have. Then I guess it is binding. If the costs are higher, the bindingness transforms into simple having a reason. Okay. The will is reason providing. Why is this the case? That's the general point. Because it would be good for us if physicians did, as I said, what the patients want them to do. So as patients, it would be good for us if the physicians did what we want them to do. But then, of course, there are limits of this kind of normative control, we can exert for the reasons given, due to the costs, and mainly due to the costs, and due also to the reasons speaking in certain cases against complying with our wishes, complying with our will. To take the case I mentioned, the Uniacke case, there might be two important reasons speaking against providing her with this pain relief treatment, actually to comply with her wish. Okay, however, they know that they don't have to be weighed against these reasons if the physician, that's a further point. So we have, sorry, I have to explain. So we have certain cases where you have very low cost cases, where I would say the patient's will is binding. No reason speaking against complying with it, and no costs created for the physician. Then it is binding. Then if you increase the costs, you have reasons to be weighed against other reasons, and it might well be the case that all things considered, the treatment that is wished for should not be actually provided, but it is still a reason to be weighed against other reasons. There is indeed, as a matter of fact, a further limit, namely, and that's the third point, sorry, namely, there is a case where these reasons are not to be weighed against these reasons, against other reasons. So if the reasons of autonomy, what I call the reasons of autonomy provided by the patient's will, and say the reasons provided based on the interests the physician takes the patient to have, that's the limit case, if the physician considers the treatment to be clearly wrong, right? So, which should be the case if all things go well, if the treatment is not in the best interest of the patient. So if he comes to the conclusion that it is clearly not in the best interest, that it would clearly be against the best interest of the patient, and for that reason wrong, then the patient's will is still reason providing, but not in the sense that the reason should be considered in the practical deliberation, carried out by the physician. Why is this the case? It's a general point, namely, if you take an act to be wrong, the reason speaking in favor of it should not play a role in your practical deliberation. Coming to the conclusion that it is wrong to do X excludes all the reasons. Joseph Rouse was talking about exclusionary reasons, exclude the reason speaking in favor of the act. Simply, they don't have to be considered. They don't go away, but you don't have to consider if you think it is wrong. And in the physician case, if the physician comes to the conclusion that he would actually violate an obligation he has. So if he comes to the conclusion, or she comes to the conclusion that it would be against the best interest, clearly against the best interest, then there's no weighing up that makes sense. That makes sense anymore. So that's the conclusion. If the physician takes the treatment to be wrong, the reasons provided by the patient's will should not be weighed against these reasons, against the reasons speaking speaking in favor of the treatment, in favor of the treatment, I should say here, right? So that's the third scenario. So you have the compliance respect scenario, the consideration respect scenario, where the costs are higher, and then when the costs are so high, not just when the costs are so high, when the reasons speaking against the treatment are so important and so of such a normative weight that the conclusion is it would definitely be wrong to undertake that treatment. The reasons don't disappear. It's not just that they go away, but as it is the case in all other cases where you come to the conclusion that an act is wrong, they shouldn't be considered, no longer be considered. To wrap this up, the patient's will, that's the idea, is binding if the costs it imposes on the physician are low. It is reason providing in all other cases, in the sense they provide in all other cases pro tanto reason, and pro tanto reasons are to be weighed against all other reasons. Probably that's the case in this example, in the Uniacke example, with the pain relief. That should be weighed against all other considerations, and then you have to come up with an all things considered judgment. Either I do it or I should not do it. It should not be considered by the physician only in the case if she takes the treatment to be clearly wrong, not to be in the best interest, or have to add against the best interest of the patient. So for instance, in the relief case, to come back to the Uniacke case again, to take that up, it's quite likely to be a case where the physician doesn't come to the conclusion it will clearly be wrong to give her the pain, to relieve her, to give her the medication for pain relief, that it is clearly wrong. The reasoning seems to rather be, well, It might be a mistake. She might have reason not to do it, or I might have reason not to do it. But I see her point, and then the question is, what is the all things considered judgment? Very hard to tell. You need to know more about these facts in such cases. You need to know more about these cases to come to a conclusion, all things considered. But if you, for whatever reason, come to the conclusion as physician it is wrong and clearly against the interest of the patient, no further consideration of the patient's will is required. So already the conclusion, I think there are good reasons to assume that respect for autonomy is more than respect for the autonomy in the minimalist sense, in this kind of non-coercion sense. I think that respect for the autonomy of the patient includes respect for the patient's will, positive will, not just the negative will. And I have to stress again, for the patient will, not because you think as a physician it is also it is indeed what she wants me to do is in her best interest or is in her interest, but simply because she wants me to act in this way. I think it simply would be good, that's the underlying principle, it would be good for patients if their positive will was respected, either in the consideration respect sense or in the compliance respect sense. In the compliance respect, I would say, is required in low-cost cases and cases, of course, where no important reasons speak against the treatment. So nothing to lose. The wish to have the surgery on Thursday or on Friday, or to postpone the surgery where it isn't a problem, where it's easily to be postponed for 3 or 4 months, then I think it is compliance respect is required. And that means the will is not just a reason to be considered, but rather the will is binding. Or in cases where you have either costs on the physician side, or then in important reasons speaking against the treatment, the reasons have to be weighed up. But the perspective of the patient, the genuine perspective, her values, her priorities, her reasons have to be taken account, and that is meant by consideration respect. And of course, there is this limit. That was the last point. The reason provided by patient's wishes or will should only be ignored if the treatment is considered to be wrong. And that's, of course, hopefully the case when the physician comes to the conclusion that it is clearly against the best interest of the patient. Okay, that was the thing I wanted to say. Thank you for your attention.
Thank you so much, Peter. I have quite a lot of questions and things, but I would hold on to it for a while, and I'll open the floor for questions from the participants over here. You can use the chat box or even raise a hand, and you can even ask the question directly to Peter too. Yes, Katharine.
Hi, Peter, that was fascinating, thank you. Just a sort of more general question, I guess, particularly in the context of my own work. I wondered if you could speak a bit about sort of how to respect patients' will when it's related to treatment, and that treatment isn't just sort of surgery or medication or something medical, something done to the body, but it's a will to be treated in a more abstract sense. So how a doctor behaves to you, what label they use for your illness, or yeah, I wonder if you had any words to say on that sort of definition.
That's a good question. I thought I would think it also, the things I said about these different forms of respect would also apply to this, the kind of treatment in this broader sense. Say that it would apply to, say, the way she wants to be treated by the physician, not just when not just with regard to surgery or medication. At least I would say it's important it's important to note that, and I think it's an important point. I'm not talking about will, that the will is in all cases binding. I guess it is rather rare that the patient's will is binding. So if you have a case binding, it would be binding if probably I would say nothing is at stake, right? So as a physician, you would say, well, why not? I mean, there's nothing important speaking against it. I'm not offended, and it's not wrong, and she doesn't ask me to do something I really don't want to do, you know, I mean, for instance, when it comes about, you think of certain sexist or racist wishes. So, for instance, I give you an example. Of course, could be easily rejected. You know, that's on the cost part, and probably in addition would easily lead the physician to the conclusion that it is wrong. And as I said, if you really seriously, you might be wrong. But if you, as a physician, come to the conclusion it would be wrong to treat her the way she wants to be treated, then of course you don't even have to consider the will further. But otherwise, I would say it would be good if people, you know, I mean, in general, it would be good if people treated us the way we wanted to be treated. So I don't see anything, you know, wrong with that, as long as we don't impose any considerable costs on others. You know, things, for instance, they really don't want to do, things they don't like to do, and then in particular, as I said at the beginning, things they consider to be wrong. But as I said, if someone comes and say, could you I want to be treated. I believe in magic forces. So and these magic forces are active on Friday. Could you treat me on Friday? Probably a silly example, but just to give you an example with low cost decisions, I would say you would even be obliged. Now, even if you think it's rubbish. I mean, even if as a physician you don't see, it doesn't make sense to you. You would say, well, I don't believe in magic forces. It's complete nonsense. But why shouldn't you? Why? I mean, we would be better off if we would allow people to be treated that way. Or don't you see that in? Don't you disagree?
Yeah, I agree with that. Thank you, Peter.
No,
I agree with what you said about it being better. Yeah, thank you.
And we have a question from Yana. She just says, hi, thank you, Peter, for presentation. What about autonomy at the end of life care when patient does not want artificial ventilation? Okay, sure. Yeah, you feel free to ask questions too.
Right. That's an interesting question. Well, in general, I think normally you need to know more about the particular case. But it seems to be a case where at least consideration respect seems to be required. I would weigh her reason. I would take that wish or that will, whatever you prefer. I would, as a physician, of course, I would take it seriously, and I would weigh it against the benefits. You know, I would ask, what are the benefits? How substantial are the benefits she might have? Because you're saying it would be beneficial. It depends on how beneficial it is. So I think it's a case of consideration respect where you have to do the weighing up. And if it is probably, if you come to the conclusion, well, it might be beneficial, but then in any case, it's a matter of whatever days or even hours. You might well come to the conclusion, all things considered, that her view. I mean, it is about consideration respect. As I said, it is about respecting her view, right? And you might not share this view. You might think, well, you should go for artificial ventilation, but it's that's the idea. It is not just autonomy in a negative sense. Don't coerce her into treatment, but it's autonomy in the sense of, yeah, if she wants to have it. If she doesn't want to or she wants to have something, take it seriously. So I would say it's you have to weigh it up and then consider the details of the case, of course, and then you have to come to an all things considered conclusion. Is that helpful?
Yes, thank you. In a way it is, but I'm coming from my research in intensive care units when procedure have a big impact on the patients, and there are constant polemical cases, and physicians are put into position to make a decision. Of course, they wait on the quality of life and the disease of the patient and everything, but still.
Yeah, but I agree. I mean, these are difficult decisions. No question about that. Extremely difficult decisions. But the thing is, the patient's perspective, and that's what it's all about. It is not to be dismissed. It's something I think, and that's the point here. It has to be taken seriously, of course, up to a certain point. I know of cases, of medical treatment where the physician just said, we're gonna do that. That's in the best interest of the patient, period. And I have to say, I don't think that's appropriate. And I think it is disrespectful. I had such a case. I have my own experience in my whole family. No, of course, that didn't apply to me, but someone I knew very well. And I remember that scene, and I think definitely that's not the way to proceed. But to have your view about what is in the interest of the patient, and what, in particular, what the medical interests are, and just to say, well, I think these interests are the interests to be served by a physician, and that's it. Is I would disagree. And then, of course, I mean, you're right. Of course, then the weighing up is not easy. I mean, the whole, how important.
Many times, physicians are put into positions conflicting and difficult, challenging, actually.
That's absolutely right, but I think it's unavoidable. It's unavoidable. I mean, that's just the way it is. I guess it is a difficult position, and whenever you have to weigh up, whenever you have, say, not clear-cut cases, and that's often the case in medicine, you have to take responsibility. But still, I think it is helpful to and also required again to take the genuine patient's perspective into account.
So,
thank you.
Thank you, Jana.
Welcome.
We have a couple of, quite a lot of questions and also raised hands. So what I'll do is I'll just follow with first the question on the chat box, and then Maria, and then Karen, and then also we follow with Hannah. Is that okay? So that I see that, the timeline. So first question I'm sorry, it's an organization here. Like, would you involve parent or caregiver's will when treating a nonverbal autistic patient? Yeah.
That's in the chat, so tell me, is that?
Yes, it's on the chat, yeah. Autistic.
Right, that's the question. I see the question. Okay. Yes, I think I would. Thank you very much for the question. I guess I would, if the patient is not able to express her own will, I would say it might be quite helpful to involve parents or caregivers as interpreters of her will. I guess, yes. I think it's sensible. Okay. And not just to proceed on a view there is an objective interest. Again, there is an objective interest to be served, but rather, is there something probably she wanted to, in the way a way she wanted to be treated, and it might be the best way to find out is to involve parents or caregivers. So yes.
And Maria, please. Maria, please feel free to ask the question. Yeah.
Hi. Thank you so much for the presentation. It's really illuminating. I hadn't heard about this consideration, respect, before. I was wondering, whilst I was listening to you, that more and more it configures the whole thing as a clash of values. So sometimes, in fact, increasingly, a number of people are finding it hard to confide in medical treatment as well, because they know that if they ever do get into hospital, or if they ever do need to get treatment, then they will have to argue about their own values and about their whole vision of life with the doctors. And so I mean, I wonder what could be done with that. I mean, maybe do you think that there could be a possibility of intervening already at the level of medical education? So to try and not induce all students that then come out as physicians to have only one set of values, and that they would then judge every other situation via that set of values that they had not maybe had before, but that they had acquired during their education years.
And that's a great question. I think you're absolutely right. That's what should be done. It should be part of the education. It should be part of, you know, in particular the ethical education. Talking about, I mean, that's what we're doing. We're talking about the principle. A lot of students in medicine get familiar with for the principle to respect autonomy, but then it depends on how we interpret this principle, and that's what, you know, what I tried to do in this talk. Of course, it's rather sketchy, but I tried to show that probably the standard understanding, which is also sometimes defended by moral philosophers, by the way, like Romer O'Neill, needs to be revised, and there are reasons to include, so to speak, the genuine, the perspective of the patient, the genuine perspective, the values and priorities of the patient, and in particular, of course, in such cases where this perspective and in particular the values and priorities are not shared by the physician. Otherwise, it's easy, of course, when you share. I mean, if you share the view, I mean, you say, well, you know, I think this treatment is indeed, you should get that treatment. Then there is no conflict. You know, there is no tension. There's nothing to be discussed. But sometimes, as I said, sometimes, and it's also what in the example shows, that was with the one example I used. Sometimes these views differ. And it is, of course, it's much harder to take, you know, the patient seriously and say, well, despite the fact that it doesn't make sense to me, you know, that's from the physician's point of view, I have to take it seriously. And that's much harder than to say, well, that's a reasonable point of view. Of course, she knows what has to be done. She knows her interest. Whereas you think, well, I'm not so sure, as the example put it, where you think as a physician, well, that might be a mistake, you know. So, and that's difficult, but I think physicians have to get used to, first of all, that kind of tension, and they should draw the right conclusions in the sense of, as I said, they're probably a revised version, a revised interpretation of this classic principle to respect the patient's autonomy.
Yeah.
And medical doctors are not always aware of that. I was talking to medical doctors. I remember one. He's also doing medical ethics. He says, well, I tend to be a paternalist, I have to say, you know, I just have the view. I mean, he said, look, at least I'm honest. I think that, you know, we have to serve the best of what we take to be the best interest of the patient, and, you know, the rest shouldn't concern us. Okay. So is that helpful, Maria? Okay. Thank you.
Yes, please, Katharine.
Hi, thank you for your talk. I enjoyed that. So my question is relating to what you think doctors or other medical staff should do in cases of attempted suicides, self-harm, eating disorders and things like that. I would have thought that the go-to answer is something relating to capacity, but then why would we think that someone who wants to die by slashing the wrist, or is content to die by slashing the wrist, has less of a capacity than someone who's content to die from cancer or something by refusing treatment?
Right. Yeah. Actually, that's an interesting question. But And it depends on it's difficult. First of all, I can think of cases where wishes to end your own life might be taken as serious reasons, you know, as reason providing, as giving you reasons to be considered, right? Depending on, you know, I think it depends on what these wishes are based on. Sometimes I guess the suicidal attempts are kind of dysfunction that has to be treated. So there is probably not really providing physicians with strong reasons, but rather with extremely weak reasons, probably with no reasons at all in certain cases. It depends on the case. But for instance, someone suffering from depression, we've got cases in Switzerland where we've got a relatively liberal legal regulation of assisted suicide. People suffering from depression over years, for 30 or 40 years, coming up with the wish to that their life not to continue, that their life should be ended. Sometimes providing physicians with I would say serious reasons to be taken seriously. I have to say, but that applies to the considered cases. I guess those really coming to a considered judgment that they're in, that they want, so kind of not under stress, coming to the conclusion that might be the best thing to do. But I don't know whether what you had in mind, which cases you had in mind asking the question. Probably you come back again.
Yeah, I guess I hadn't really sort of made that distinction in my own mind, but yeah, I was perhaps thinking of someone who, who sort of thought things over and thought, you know, the way my life is, I don't want to carry on, or someone has an eating disorder, they're gradually sort of eating and rather not eating themselves to death.
Well, I guess in certain cases it's clearly a result of a dysfunction. Actually, having this tendencies or eating disorder is probably just a symptom of a disease. And in certain cases, it might well be a considered desire. In other cases, you know, the desire to end your life, that might be a well considered desire in certain cases. So I think one has to distinguish between the different cases, and the details count for a lot here. But I could think of cases where it's obviously something that needs psychiatric treatment, and people could, I mean, you've got such cases where it's just a disease, right? And then it's also, and then it's the force, say the reason force, the strength of the reason provided by such people is probably not that. Well, the reasons are probably not that strong, and quite weak, and ask for treatment rather than to be taken seriously.
Okay, thank you.
Thank you, Karen.
Okay,
we have a in the chat box, Peter. Hannah.
It's a long question. Yeah. Pauline.
Do you have something to say?
Okay. Okay. I think this is an excellent example. It's an excellent example for actually having your own reasons not to continue with the treatment. I think you're right. You have a right to decline this. That seems to be your conclusion. I'm sympathetic to this conclusion, and probably also should be shared by the physicians. That's, you know, what I was getting at actually. Having a broader view of autonomy would include to accept such decisions, of course. Yeah. Even if it's hard to understand. Again, that's exactly the challenge of the reason of what I call the reasons of autonomy. You know, reasons of where you've got genuine reasons of autonomy. I would say the reasons are such that they are hard to share for others. And actually, that's exactly the challenge, right? Otherwise, I mean, autonomy wouldn't be a challenge, and the demand to respect autonomy would be a rather trivial demand. It would be a rather trivial principle, but I don't think it's a trivial principle, because it is a challenge, and in certain cases, like probably a very serious challenge, because they might have problems to understand you, and that's what they have. They're what they should do.
Right. So I was wondering.
Okay, sorry. Yeah.
So no, I mean, I was just wondering, when you use the word best interest, right? I mean, when we decide it's finally about the best interest principle, let's say if you're using, is it not already like kind of a slippery slope in getting into the direction of paternalism in that sense? Would you consider that? Or, I mean, I was wondering, because best interest can be subjective from a patient's point of view, that is a patient-centered model or a physician-centered model. So, and now that goes back to the consideration respect point of view of, you know, of you look at what she's saying, as I understand, it's a subjective experience point of view, that patient's subjective experience plays a very important role. Then does it, as I understand what you're saying, it's a weaker argument you're saying, the normative significance is a bit weaker, you said. Then my question is, then does subjective experiences provides by default as a relatively weaker normative weight? Would you, I mean, do you see, is that I mean, I would see that as a bit of a problematic thing, but do you consider that as an issue?
Well, actually, we shall discuss this point, discussing Katharine's paper then, the importance of the subjective experience and the subjective point of view. But first, probably I might answer your best interest question. I mean, it seems to be the standard understanding is that the obligation physicians have, they're under an obligation to act in the best interest of the patient. So that's, now of course, that raises questions of what is the best interest? Is it the best interest from their point of view, or is it the best interest from the patient's point of view? That's a difficult question, but the only thing I could say is it seems to be quite reasonable to say the principle that tells us that they have an obligation to act in the best interest of the patient seems to be quite acceptable, right, as a starting point. And physicians have to come to a conclusion what is in the best interest of the patient, right? They might be wrong for various reasons. We all might be wrong, you know. We might be wrong with regard to our own reasons. With regard to our own interests, for instance, you know, I might have a certain view what is in my best interest, and I might be wrong about that. But still, if a physician comes to a conclusion that X is in the best interest of patient A, it should play a role for her or for him. But I mean, it should play. It would be problematic to dismiss the best interest perspective out of hand. I mean, that's certainly not a reasonable way of proceeding. But I take it that the autonomy principle tells the physician to consider not just the best interest, what she thinks is in the best interest, but there are other considerations to be taken into account. Namely, say, well, things that have genuinely to do with autonomy, you know, with the priorities of the patient, you know, and you have to put emphasis on what she thinks is important, what she wants me to do. And that has to be somehow, I think, weighed up against each other. I mean, the best interest versus autonomy. But of course, I see that the best interest, that you know, is in itself is a topic that should be treated in a presentation because it's a difficult issue. And but still, I guess the only thing I can say here is it necessarily plays a role in the practical liberation of physicians. That is, I mean, it would be bizarre if a physician said, I think it's in the best interest of patient A, treatment X is in the best interest, clearly, that's what I think is clearly in the best interest of patient A, but it won't play a role in my practical liberation, what I should do, or what I'm going to do. That would be bizarre. That's what I mean. It should play a role. It has to play a role. And it sometimes is dominant because the standard, as I said, the standard view says it it can only be limited by the negative will of the patient. You know, you might come to the conclusion it's best interest, but the patient refuses. And that's on the standard interpretation, also standard practice. This is accepted, right? The negative will. You refuse to undergo the treatment. That has to be accepted, even though the physician might think it's clearly in the best interest to undergo the treatment. But it is not accepted in the positive will case. There, that's the point. And that should be limited by the positive will. Just limited, of course, because it can't be, as I said at the beginning, and that's an interesting philosophical point also, the positive will is clearly for good reasons, can't be binding as the negative will is. Can't be for various reasons. I wanted to spell out in the talk.
Okay, I see. And with subjective experience, I know we are running out of time, but yeah, if you have anything.
We actually, I think we should probably we should postpone this discussion because we're going to touch upon this, the importance of subjective discussing Katharine's paper. Exactly. I have prepared a comment on her paper, so probably we pick it up then or again.
That's perfect. Yeah. So thank you so much, Peter. And this is quite a lovely discussion we had and engaging, of course, and we will continue this maybe during the open discussion time after Katharine's talk. And so maybe we'll get back in 10 minutes. Is that okay? We'll take 10 minutes break and we'll be back for Katharine's talk. And we are looking forward for that. maybe we'll just wait for another minute. Is that okay, Katharine? Okay, so maybe I'll start now. So welcome back, and we have our second speaker, Katharine Cheston, and she'll be presenting the paper titled "The Wish to be Treated with Dignity, Respect, and Empathy, and Disrespect and Shame in the Context of Medically Unexplained Illness." This is one of the title which I really like. It's like everything packed on the title which we want to discuss, you know. So Katharine is a PhD student at the Institute for Medical Humanities, Durham University, and it is funded by Wellcome Trust. Her doctoral research focuses on complex, poorly understood medical conditions and investigates how these conditions can be a uniquely potent source of shame. Inherently interdisciplinary, her project combines literary and qualitative methods, comparing contemporary life writing with interviewed testimony from experts by experience, in order to think more broadly about issues of diagnosis, shame, and stigmatization. So over to you, Katharine.
Thanks, Supriya. I'll just share my screen. Oh, can you see that? Great, thank you. Just minimize that picture. Brilliant. Yeah, thank you very much, Supriya. It's really kind of you. And it's a privilege to be here today and take part in what has been a really brilliant seminar series. So as Supriya said, my title, my presentation is entitled "The Wish to be Treated with Dignity, Respect and Empathy, Disrespect and Shame in the Context of Medically Unexplained Illness." And I'll start with this citation from Sarah Ramey's memoir, entitled "The Lady's Handbook for Her Mysterious Illness, a Memoir," which was published in 2020. Ramey experiences, as the title suggests, a mysterious illness. She lives with debilitating physical symptoms, including excruciating pain and debilitating gastrointestinal issues. But for most of her memoir, no biomedical explanation can be found, despite extensive medical testing, and her symptoms remain, so to speak, a mystery. Towards the end of her memoir, Ramey writes, "I just wanted people around me to treat me the way they would treat any other sick person they knew, with dignity and care and respect. Why was that too much to ask?" In this quotation, Ramey appears to set up a distinction between other sick people who are treated with dignity and care and respect, and those living with what she terms mysterious conditions, who by implication are treated with neither dignity nor care nor respect. It's this final noun, respect, standing in pride of place at the end of this tripartite clause, which I find the most interesting. Just as it echoes out into the blank space on the page, so it echoes across other accounts and documents pertaining to these so-called mysterious illnesses. For example, discussions of respect featured in the recently updated NICE guideline for myalgic encephalomyelitis or chronic fatigue syndrome, MECFS, which this updated guidance for NICE, National Institutes of Health and Care Excellence in England, recognised to be a complex chronic medical condition affecting multiple body systems, for which the pathophysiology is still being investigated. Respect was most prominent in one of the appendices, which details a consultation with people who live with severe MECFS. This is a population who are almost without exception either housebound or bedbound. This consultation was carried out by the University of Manchester Centre for Primary Care via an online questionnaire. One of the questions that people with severe MECFS were asked was, were you treated with respect and empathy, understanding by health and social care professionals? As you can see, many of the responses make for grim reading. They describe being dismissed and belittled, with one respondent remarking that they had been treated with contempt. This particular section included the poignant conclusion that severe MECFS patients wish to be treated with dignity, respect, and empathy by the healthcare professionals they encounter. That those who are so severely unwell should express a wish not just for medical treatment, but also to be treated in a more abstract sense with respect is eye-opening, and I think that it certainly merits further investigation. This paper will analyse experiences of respect, disrespect, and their consequences as expressed in two very different texts, which detailed first-hand experience of what Ramey terms mysterious illnesses. One is Ramey's aforementioned memoir, and I'll bring this into conversation with another account of a mysterious illness that was made in the context of a semi-structured interview. I'll say more about this later, but ultimately through this analysis, I will interrogate the following questions. Firstly, I want to know what people like Ramey who live with these particular kinds of illnesses might mean and understand by respect. Ordinarily, I'd provide my own definition of respect here, drawn from academic contexts. However, I've chosen not to do this today as I want to focus through a detailed reading of two accounts on what respect might mean to these people in the context of their own lives. I also want to explore what constitutes respectful or indeed disrespectful treatment in the context of these so-called mysterious illnesses, and here I'll focus on treatment within the clinical encounter itself. I'll then touch upon what some of the effective consequences of encountering disrespectful treatment might be for people experiencing these kinds of illnesses, and these include shame. Again, my focus here is less on the theorization of shame, as we've seen in other presentations in this series, but I want to consider what shame might mean to people with these sorts of illnesses. Finally, I'll look beyond the clinical encounter and its consequences in order to interrogate Ramey's question, why is respect really too much to ask for those with mysterious illnesses? Before I turn to these first-person accounts, however, I will first pause to provide further elucidation of the terms that I've been using to refer to these illnesses, those which Ramey terms mysterious illnesses and which I referred in the title of this presentation as medically unexplained illness. The clinical literature uses nosological categories such as persistent physical symptoms, PPS, or medically unexplained symptoms, or even medically unexplained physical symptoms, which MUS or MUPS, to describe situations in which a patient reports somatic symptoms, which can be severe or undisabling, but clinical and laboratory examinations do not reveal a structural or pathological explanation. Alongside symptom-based categories such as non-cardiac chest pain, these labels also encompass, controversially, symptom clusters that include poorly understood syndromes such as irritable bowel syndrome, IBS, which you might have heard of, and also ME/CFS, which I mentioned before, for which there are actually growing bodies of biomedical evidence. These phenomena are by no means rare. It's thought that in the UK, between 25 and 50% of all GP consultations concern symptoms that are not medically unexplained, although it should be noted that these authors in this particular study and others suggest that actually most of these symptoms are transient and that to experience persistent physical unexplained symptoms is much more rare. However, MUS have also been prevalent in secondary care. One study, which was carried out a while back in the late 90s in London, found that 66% of referrals to gynecology clinics and 62% of referrals to neurology clinics fulfilled criteria for medically unexplained symptoms. So it was the majority of people in these situations were given a diagnosis of medically unexplained symptoms. So these conditions clearly represent an important potential area of research, but there is significant dispute surrounding what we should call them. Many with lived experience reject the clinical labels, especially MUS and MUPS, which might go some way to explain why Ramey eschews the clinical in favour of the term mysterious illnesses. Indeed, in my own doctoral research, I refer to these conditions as complex and poorly understood medical conditions, following engagement with my project advisory group, which is composed of 8 women with lived experience of these illnesses. The term medically unexplained illness, therefore, is not one I employ uncritically, hence the scare quotes to draw attention to and question our usage of this label and interrogate what it might do. There's also significant debate and dispute surrounding how we should define and therefore study these conditions. Many people living with supposedly medically unexplained illnesses strongly believe that their symptoms have an organic cause that will eventually be discovered given time and research funds. And indeed, some of these people, including Sarah Ramey, do eventually discover a medical explanation for at least some of their symptoms. This part of the patient population express a wish for their conditions to be studied by sort of, I guess, researcher detectives who possess enough curiosity and enough persistence to solve these somatic mysteries. However, this is at odds with many clinicians, such as neurologist Suzanne Uniacke, who has published a number of memoirs on her experiences including It's All in Your Head, True Stories of Imaginary Illness, which was her first book that was published in 2015. O'Sullivan is by no means alone in her belief that in the majority of cases of medically unexplained symptoms, no disease is found because there is no disease to find. If symptoms cannot be medically unexplained or medically explained, then the cause is most likely to be psychological or behavioural. In other words, that these conditions are medically unexplained is explanation enough. The mystery has already been solved. It's in this context that the two accounts of mysterious or medically unexplained illness and a study were told, produced or published. The first of these accounts, as I've said, is Sarah Ramey's memoir, The Lady's Handbook for Her Mysterious Illness, which was published in the US in 2020. Ramey's memoir tells an emotive account of her experiences of seeking healthcare for a constellation of complex and mysterious symptoms. The second account is told by a woman who we will call Aria. Aria is a British Asian Indian woman in her 30s who lives in the UK. Aria, like Sarah Ramey, lives with gynecological and gastrointestinal symptoms for which healthcare professionals cannot find a structural cause. I interviewed Aria earlier this summer in a semi-structured qualitative interview, and this analysis draws from a transcript which was produced verbatim by a professional transcriber from an audio recording of our interview. Both women experienced gynecological and gastrointestinal symptoms that are, at least for a time in Ramey's case, deemed to be medically unexplained. Yet on paper, text and transcript appear worlds apart. They're separated by the Atlantic, Aria's in the UK, Ramey's in the US, and their accounts are expressed in entirely different genres. Ramey's memoir, at least in its hardback edition, is a large tome. It's composed of over 400 pages of finely considered prose, which we imagine have been drafted and redrafted again over a significant period of time. The memoir has clearly been written with an intended reader in mind. It opens on the very first page with the words "Dear Reader," and its imaginative language, adorned with metaphor and rhetoric, has clearly been crafted to create an intended effective response in this reader. The interview transcript, however, provides a record of a spontaneous account, told in real time during a one-to-one conversation which lasted 1.5 hours. Moreover, while Ramey's memoir carries her real name, along with a headshot in the back inside cover, the interview was carried out with the guarantee of full anonymity. Aria is, of course, a pseudonym. I appreciate that might seem odd to bring two such different texts into dialogue in the same paper or presentation. However, I've done this in order to draw attention to the expression of these experiences, to the ways in which these accounts are told, whether written or spoken. Both transcript and memoir describe experiences like shame, like encountering disrespectful medical treatment, which are often hidden and which can be hard to talk or write about. I hope to show how attending to the language, imagery, form, and structure of these two very different first-person accounts can reveal aspects of these hidden experiences that might otherwise go unseen or unnoticed. My analysis of these texts will be divided into two sections, followed by some conclusions. The first section, Clinical Encounters, delves into Aria's and Ramey's experiences of seeking healthcare for their medically unexplained symptoms, and it analyses these experiences through the lens of respect. The second section elucidates the consequences of how they're treated in these clinical encounters, and here I argue shame is a crucial central feature. So, clinical encounters. Both Ramey and Aria describe a sudden onset of severe gynecological symptoms. Aria's pain appears out of the blue. She says, "I literally, what seemed like out of the blue, started getting these sharp shooting pains in my clitoris." The pains, which were, it was kind of like a random, sharp, nerve-like shooting pains, is intrusive. It's severe enough to prevent her from working. The onset of Ramey's pain, however, doesn't appear to be as random. Ramey tells her readers on the very first page of her memoir that she knows exactly how her story started. "It all began," she writes, "so many years ago with a cool, luxuriant swim in a Walden pond." She spends the next day in the emergency room with a UTI or urinary tract infection, contracted, she implies, from the water, which is presumably stagnant. She's prescribed antibiotics, sent home and told the infection will soon pass. But, she writes, "the UTI stayed. We joked and called it my PUTI or permanent UTI, and I laughed along with the rest. But in private, in the bathroom, I was profoundly unamused." Rami might feel that she has to joke along and make light of her symptoms, but her pain, like Aria's, is clearly debilitating. It's interesting that Rami should make a distinction between public and private experiences of illness here. To state what's perhaps obvious, gynecological pain brings additional affective challenges, as Aria reflects. I think having pain in your vagina is like, you know, as much as I'm quite open-minded and all this kind of stuff, like it is a shameful thing. Because, you know, literally some of my friends did jokingly at the beginning ask like, oh, have you been masturbating too much? Or did you just use like a weird dildo or something? And I'm like, no, not at all. Or have you been having too much sex? I'm like, no, not at all. It might seem that even just saying the word vagina is enough to provoke awkward laughter, which I didn't imitate when I read out that section. Having pain in your vagina is, as Aria says, a shameful thing. Aria's words echo Renita Sorensdottir's essay in the 2013 edited collection, Dimensions of Pain, in which she described vulvar pain as a shameful pain. It's something to keep private, to keep hidden, until, as for both Aria and Rami, its severity forces it into the open and into conversation. Just as Rami and her friends joke about her permanent UTI, Aria's friends also joke about the potential causes of her pain. This onslaught of intrusive personal questions seems to have been difficult for Aria, but it's perhaps a sign of our collective awkwardness and embarrassment surrounding these kinds of pains. Maybe we just don't know how to react to them. We might, however, expect healthcare settings to be able to react to gynecological pain with less awkwardness and more compassion, and indeed to make space for the fact that this pain can be difficult and embarrassing to talk about and may even be considered shameful. However, this is not the case for Aria. Shortly after the sudden severe onset of her vulvar pain, Aria attempts to seek healthcare. I did all the right things, she said, like contacting the GP, and I got completely fobbed off. Like they were all like, it's nothing, just ignore it, like it's nothing kind of thing. She has 5 GP appointments before being referred to a gum clinic or sexual health clinic. And after this, her husband pays for her to see a private gynecologist, where she says, again, they were like, oh, it's nothing. Aria is passed from proverbial pillar to post, and she is, in her own words, completely fobbed off. With her tests coming back clear, Aria struggles to convince any of the many doctors she sees to take her and her pain seriously. In the context of the interview, unlike the memoir, as we will see later, it's not possible to recreate conversations that take place within clinical encounters. And you'll see that I've not added speech marks to this excerpt. Instead, it would seem that Aria summarizes what she took to be the key message of these conversations. And we might imagine that she's gauged this not just from her doctor's words, but also from their tone of voice and perhaps even their body language. The utterances like and oh do a lot of work here. At the start of this excerpt, we have, they were all like, it's nothing, like just ignore it, like it's nothing kind of thing, which is mirrored at the end by, so again, they were all like, no, it's nothing. Aria doesn't comment on this treatment, but it's clear from what she says and also from the way that she said it in the interview, in both the tone of her voice as she imitates her doctor speaking as if brushing her complaints away, and in her hand gestures, which from memory enacted this brushing, sweeping movement. It's apparent that she considered this treatment to be both dismissive and belittling, as her pain is reduced, as she says, to nothing. Aria's experiences of secondary care are no more positive. The first gynecologist appointment I had, she told me, the woman was like, there's nothing wrong with you. Are you sure you're not allergic to cheese or chocolate? This particular appointment seems to have been a memorable one for Aria, who returned later in the interview to expand upon her previous comments. The gynae that I told you about, who said, oh, it might be cheese or chocolate that you're allergic to, maybe that's it. I actually literally, she was like, there's nothing wrong with you, just go home, use more lube during sex, basically. And I was like, I'm not having fucking sex, like I wouldn't be using. She was like, oh, use more lube, you'll be fine, kind of thing. In each of the 2 times that Aria discusses this particular appointment, she attributes the same phrase to the gynecologist, there's nothing wrong with you. This phrase has echoes of her GP's and private consultants' comments, oh, it's nothing, but it appears all the more distressing. Seems like a more explicit dismissal, indeed rejection, of her pain and of the impact it's having on her life. In response to her gynecologist's advice, just go home, use more lube during sex, Aria appears to try to express to the gynecologist the limitations her pain imposes on her, saying, and I was like, I'm not having fucking sex, like I wouldn't be using. She was like, oh, use more lube, you'll be fine, kind of thing. The impact of her pain on her relationship with her husband was perhaps too painful or too personal to discuss in detail during the interview, as it disappears in the pause marked by the ellipses here. However, Aria's expletive shines some light on the frustration she felt, but undoubtedly couldn't express, or at least didn't express in this way during the appointment, while the return of the dismissive phrasing attributed to the gynecologist, oh, use more lube, suggests that she was made to feel not only as if her pain didn't matter, but also as if her suffering as a result of this pain didn't matter either. Aria doesn't use the word disrespect in either of these excerpts. Yet the impression I got in our interview, and that I continue to get from the transcript, was that she perceived the treatment she received by these healthcare professionals to be distinctly disrespectful. Her pain is dismissed and belittled, and I don't think it's a coincidence that I've used the same verbs here, dismissed and belittled, as the people with severe ME/CFS use in their responses to the NICE consultation that I quoted earlier on. This begs the question, can patient testimonial experience only be respected and not dismissed, belittled, or indeed rejected, when it is corroborated by the results of objective medical testing and imaging that healthcare professionals currently have at their disposal? Both Aria and Rami are eventually successful in obtaining a diagnosis. Aria is diagnosed with vulvodynia, which is vulvar pain of unknown etiology, and Rami received a diagnosis of a rare parasitical condition, which I won't try and name, although this is ultimately not the solution to the mystery that she hoped it could be. However, this diagnostic label comes at a cost for Aria, who actually describes the diagnostic process as traumatizing. She says, actually getting the diagnosis is traumatizing in its own. It's because it's like you're not believed, I think. I think it's almost like every time I was treated, like I was making up what I was saying, like I'm just this person that's over-exaggerating. And actually I'm the opposite, I underplay what's wrong with me. So yeah, I think the way the medical system went about dealing with me was completely like all the wrong things to do almost. What I find particularly noteworthy about this passage is the aspect of the experience that Aria describes as traumatic or traumatizing. It's the fact that she was disbelieved and was repeatedly treated like she was making up what she was saying. We've already analysed examples within Aria's reported clinical encounters of disrespect for her own account of her own illness when it does not correspond to objective medical testing. What Aria is describing here, however, goes further than this. She seems to be expressing experiences of a more generalised disrespect directed at her as a person. She describes being misunderstood and misrepresented, being treated like I'm just this person that's over-exaggerating. And here her use of the word just indicates that she might have felt that it wasn't just her pain that was dismissed, minimised and trivialised. She felt personally belittled by these experiences. Aria appears to have found this treatment deeply insulting, and she took care to correct this misreading of her personality in the interview. The implication seems to be that in the absence of an objective explanation for her symptoms, it's Aria herself who's at fault. If there was nothing wrong with her from a biomedical perspective, it must be Aria herself, her personality and her behaviour that's wrong. I think we could say that the disrespect that Aria and Rami experience in clinical encounters is multi-layered. Firstly, their pain itself is dismissed when it's not confirmed by objective evidence. Secondly, their account, or we might say narrative of their experience is minimised and even rejected. And thirdly, they feel insulted as they're met with disrespect for themselves as people. This is, I believe, most apparent in Rami's extended discussion of her encounter with a renowned urologic surgeon, which brings Aria's description of the diagnostic process as traumatizing into a new light. And I will warn that the experiences that I will discuss over the following slides are quite distressing, and they also concern explicit discussion of gynecological procedures. This appointment takes place a number of years after Rami's swim in Warden Pond. After a botched procedure to cure her permanent UTI led to her developing life-threatening septic shock, which leaves her with lingering mysterious symptoms. And it's these lingering mysterious symptoms that bring her to this appointment with the renowned urologic surgeon. So Rami travels cross-country to attend an appointment with this surgeon, only to find that, like everyone else, he had not known what to make of her case and had referred her down the line. A few days after her initial appointment, however, Rami contacts his office again to discuss what she calls her extremely swollen, bright red left labia. She speaks to a junior on-call physician who listens to her concerns and agrees that the next step should be to conduct a labial biopsy, as well as other examinations under general anaesthesia. When Rami arrives for her scheduled appointment with the urologic surgeon, however, she's shocked to find that he is not at all happy to see her. She writes, "Now that I'd returned, after he had already said he didn't know what to do about my case, he seemed to have transformed from a once dispassionate physician of some renown, Dr. Jekyll, if you will, to a very different man, a urogynecologic Mr. Hyde. Very begrudgingly, Rami tells us, this urogynecologic Mr. Hyde agrees to examine her. When she asks him what she should do about her swollen labia, the surgeon retorts, "I would stop worrying about it so much." Reluctantly, the surgeon agrees to do the biopsy, but only using local anaesthesia. Ramy tries to insist on the general anaesthesia, but Hyde fixed me with a look of such naked disgust, I felt afraid. He looked up at the large ticking clock on the wall and told me he didn't have time to take me to the operating room for something so trivial. I could toughen up and have the biopsy done right there with a local anaesthetic, or I could leave. It was my choice. Ramy is confused and conflicted. Why, she wonders, wasn't this man acknowledging that we'd come all the way to Phoenix because I couldn't sit in a chair, wear pants, have sex, or even have a gentle breeze on my vagina without fiery pain? Painting her concerns and her pain as something so trivial, Ramy's disabling and restricted pain is neither acknowledged nor apparently respected by this renowned surgeon. Feeling vulnerable, she's partially clothed, she has got her feet in stirrups. Ramy agrees to the procedure, deciding she needed to toughen up. What follows makes for difficult and distressing reading. Mr. Hyde took out a long needle filled with lidocaine, set his jaw, told me to stay calm, and inserted it into my bright red, swollen left labia minora. I screamed so loud the nurse had to hold my shoulders down. The surgeon pressed his eyes shut. He looked exasperated. I began to cry. Ramy waits for 10 minutes as instructed for the lidocaine to take effect. After the allotted 10 minutes have passed, the area is still not numb, much to the surgeon's displeasure. Sighing, he inserted the long needle into my bright red, swollen left labia minora again and injected the lidocaine again. I was screaming as if my own child were being murdered. He poked it again and I could still very much feel the touch and the pain, but he declared that just wasn't possible, that there was no way I could feel anything anymore, told me to be quiet, and proceeded to start cutting into my labia. I've never cried so hard in my life. And throughout the procedure, Mr. Hyde would not look me in the eye. He scooped 3 oozing red samples onto 3 glass plates for the laboratory. Then, without saying a word, he cauterized the wound. And when he was finally done, he simply walked out of the room. Ramy's screams are met with exasperated and seemingly disinterested silence. The surgeon denies her pain outright, declaring that it just wasn't possible. We might imagine that it would be difficult to find a more flagrant example of the disrespect that patients with complex and seemingly medically unexplained health conditions encounter from healthcare professionals. Ramy's account of her own pain, even when expressed in such visceral, primal form, is completely dismissed by this surgeon, who doesn't even offer her the simple courtesy of looking her in the eye. What seems all the more distressing, however, are the more subtle forms of disrespect that Ramy occurs in this appointment. After the biopsy, the nurse asks Ramy which pain medication she would prefer. Ramy declines. She explains, tolerate pain medication well. The nurse is insistent, and eventually Ramy agrees to take a single dose of Percocet, which is an opioid medication containing oxycodone and paracetamol. However, the nurse returns with an ice pack, but no medication. She reports, Ramy writes, eyes fixed firmly on her shoes, that the surgeon had refused to prescribe pain medication for me. Eyes on shoes, she said that this particular surgeon didn't like to give pain medication to patients like you. When Ramy asks as to the reasons for this refusal, the nurse explains that patients with chronic pain often go to great lengths to obtain opioids. The impacts of the nurse's comments appears, if possible, even more agonizing for Ramy than her surgeon's scalpel. I realized that I was trembling and tears were falling down my face. I could not think of a single word to say. All I could think about was what kind of person you would have to be to travel long distances for a vaginal biopsy and cauterization just to score 1 tablet of Percocet, and that my doctor thought I was that person. I took the ice pack in silence, put it wincingly between my legs, sank into the wheelchair, and turned my face away. Ramy's screams are replaced by quiet tears. She is reduced, finally, to silence. As she sinks into the wheelchair and turns her face away, as if ashamed, Ramy appears to admit defeat, overwhelmed by her doctor's misjudgment of her and her motivations. The tears falling down her face at the end of the appointment are not the result of the physical pain of the botched biopsy, but the emotional distress upon encountering such profound and painful disrespect for her experience, for her pain, and for herself. I'll now look at the consequences of these clinical encounters. Ramy's doctor did not know what was wrong with her. This fact did not appear to sit comfortably with him. Indeed, it could be said that being confronted with the limits of his own knowledge, embodied by Raimi and her inexplicably bright red swollen left labia minora, was the catalyst for what Raimi describes as his transformation from Dr. Jekyll to Mr. Hyde. This appears to provoke an irrational emotional response. Raimi wonders why he seemed, in her own words, so pissed off at her, as well as what appears to be a decidedly irrational and illogical explanation that Raimi, that anyone, would voluntarily put herself through the excruciating pain of a labial biopsy and cauterization for the sole purpose of taking one opioid-based painkiller. There appears to be no place in the clinical encounter, in Raimi and Ari's experiences, to acknowledge the limits of medical knowledge. And this, I think, has disastrous consequences for patients with so-called medically unexplained illness. As Aria summarizes eloquently here, she says, I think we are, as a society, we are conditioned with Western medicine being like this superior thing. So it's almost like we place them as this like superior being of knowledge, which they are in a lot of ways. Like we've got cancer treatment, we've got vaccines, like it's amazing what like medicine's achieved. But I think there's some things they just don't understand. It almost was like they kind of weren't able to admit it kind of thing, and just sort of fixated on me not taking the medication as the source of the problem. Aria senses that her doctor's unwillingness or perhaps inability to admit that there are some things that they just don't understand may have contributed to their inability to acknowledge her pain in a compassionate way. Instead, they just sort of fixated on her behaviour, her not taking medication, as the source of the problem. This has parallels in Raimi's memoir. Raimi's surgeon fixated, of course, on her supposed drug addiction and told her that she needed to stop worrying and toughen up. Indeed, in the more expansive context of her memoir, Raimi makes remarkably similar statements to Aria. For example, she writes that the ring kicker was, every single time the heroes did more damage, every single time people continued to treat me in ways that were hurtful and demeaning, and every single time the positive thoughts did not work. Reader, I could not stop myself from boomeranging back to the message I've been programmed with subtly and unsubtly at every single step of the way. The problem was me. As they continue to be treated in ways that are hurtful and demeaning, both Aria and Raimi are forced to come to the same conclusion every single time, where the rhetoric here of the literary text, with its repeated clauses, allows the pain of this self-blame to ring out. It would seem that in these clinical encounters where subjective testimony abounds but objective medical evidence is not forthcoming, the problem's not the pain. The problem's not even that medical and scientific knowledge are incomplete. The problem is the patient herself. Raimi and Aria are certainly left with the distinct impression that their pain and suffering is their own fault. It sort of feels like it's your own fault somehow, Aria admits, that you're like in this situation sort of thing. And because the system are acting so normal about it and dismissing you, you're left with nothing but yourself. With no medical explanation and encountering repeated dismissal from healthcare professionals, Aria is, as she puts it, left with nothing but herself. This leads for Aria to an intensely distressing sense of shame. She says, at my most weakest, vulnerable points, I did feel ashamed, not must have. I definitely did. When I had all those back-to-back conversations with the GP, when I went to the gynecologist. But in those moments, I think there were moments where I think I did have a crisis of disbelief. Like, I was just like, oh gosh, this is really bad. Like, why did this happen to me? Like, maybe I did something wrong. Like, maybe I worked too hard, or I don't know what it was. Vulnerable and feeling weak, Aria appears to start to doubt herself. In her desperation for an answer to her pain, she tries to find an explanation within her own behavior, concluding, maybe I did something wrong. Left alone and helpless, left, as she describes, with nothing but herself, Aria appears to blame herself for her own pain, provoking a deep and intense sense of shame. Almost all of the women with medically unexplained illness that I've interviewed have expressed similar thoughts of self-doubt, even self-blame, and certainly shame. These thoughts often spell out at the very end of the interview, and they're told in whispered tones as if the thoughts themselves are shameful, but there's still this desperate need to voice them. These crises of disbelief are often, like Aria's, phrased as questions towards me as the interviewer. They say, am I to blame? Did I deserve this? Am I not good enough? They speak of a deep, secret pain, one that rears its head during their most weakest vulnerable point, as Aria says, one that appears to be has the potential to be even more distressing than the physical symptoms they endure. Ramey's memoir sets out just how distressing this self-blame can truly be, reflecting upon the desperation of her situation and the fact that the doctors were out of options. Ramey feels, as she says, lost. I really had no idea what I could possibly do to change the situation. I had done absolutely everything. This must be what I want, I conceded. I accept I may have created my own illness, I wrote on a sticky note and attached it to my mirror. Take responsibility, I wrote on another. What you resist persists. I decided I just needed to accept that I was the attention-seeking malingerer those emotional healers had hinted at. I didn't have a parasite, I was the parasite. Something was so perverted and so buried inside of me, no one could dig it up. I must not want them to, I reasoned. The hidden secondary gains were too great. There was no other explanation. I am a monster, I thought. It may seem hard to imagine how Ramey, in her anguish and despair, could have come to such a tragic conclusion. She's desperately unwell with severe symptoms that dictate each and every part of her day-to-day life. And as we have seen, she's lived through deeply traumatic and traumatizing experiences with those who were supposed to help her. Yet she is the one describing herself as a parasite and a monster. The cruelty expressed in italic, mimicking Ramey's inner voice, is shocking. Ramey appears to be actively blaming and shaming herself by attaching these sticky notes to her mirror, where of course you'll see them next to her face. But as she states in bleak and resigned tones, there was no other explanation. Evidently, those who live with medically unexplained illnesses experience both somatic and social suffering, with the pain of shame adding significantly to the illness burden. This passage of Ramey's memoir is even more hard-hitting in that it puts Aria's interview transcript into a stark light. Could Aria and the other women I've interviewed share Ramey's sentiments? Might this depth of suffering lie hidden and unarticulated behind their words? Regardless, what remains clear in the comparison of these texts is the need to make space for these feelings, whether they're written elegantly and expansively or whether they're spoken in a hurried whisper. I want to open my conclusions with a citation from the last pages of Ramey's memoir. Throughout her memoir, Ramey often addresses her reader directly, creating a sense of kinship with this reader who, she seems to presume, probably quite rightly, this is after all a handbook, has opened her memoir as a source of both practical and emotional support. In this citation, Ramey is particularly frank with this imagined reader. She writes, "And I know that these illnesses can feel like falling into an abyss of ugliness where all control is lost, where healthcare providers are cruel, and where your life seems like it will forever be battered back and forth at the whim and mercy of your doctors and your body." Having journeyed through this abyss of ugliness in this presentation, you might find it interesting to note that Ramey has chosen this particular order for the last part of the sentence. She writes, "your doctors and your body." Patients with so-called medically unexplained illness suffer a double burden, that of physical suffering and traumatic experiences of healthcare systems. As we've explored, the disrespect that Ramey, Aria, and potentially others encounter from healthcare professionals takes three interconnecting forms. Disrespect for pain when it's seen as medically unexplained, disrespect for the patient's account of her own pain, and finally, disrespect for the patient herself. The natural consequence is, of course, a uniquely distressing combination of social and somatic suffering that characterizes the experience of medically unexplained illness, where shame is an inevitable, inescapable feature. You will undoubtedly have noted that neither Ramey nor Aria uses the word disrespect in reference to their experiences with healthcare professionals. Although here, Ramey's comments that healthcare providers are cruel could not be interpreted, I think, in any other way. Instead, they choose phrases like completely fobbed off. They talk about being treated in ways that were hurtful and demeaning. They describe being dismissed, disbelieved, and being made to feel as though their pain were trivial, unimportant, or even non-existent. They speak of being made to feel as if their pain were their own fault. They write and speak of feeling intensely alone and of the desperation for a healthcare professional to listen to their story and to take it and them seriously, to acknowledge and validate their suffering and the very real, very distressing impacts that it's having on their lives. Why these eloquent and articulate women do not use the word disrespect is certainly in itself an issue worthy of discussion. Perhaps the word remains unspoken because it's so obvious. Perhaps simply and sadly, they have learned not to expect better treatment. Perhaps we might think they don't feel they deserve better treatment. Whatever the reasons, it's clear that experiencing an illness considered to be medically unexplained or indeed mysterious leaves one vulnerable to experiencing disrespectful treatment from healthcare professionals. And it's equally clear that the consequences of this disrespect are significant and worthy of attention. Finally, I'll return to the quote from Raimi with which I started this presentation. I just wanted people around me to treat me the way they would treat any other sick person they knew, with dignity and care and respect. Why was that too much to ask? I wish to propose one reason why being treated with dignity, care, and crucially respect might appear to those who lack a biomedical explanation for their physical symptoms to be too much to ask. Respecting a patient with a medically unexplained condition, listening to them and acknowledging their pain as genuine requires both healthcare professionals and laypersons alike to respect the limitations of medical science and the consequences of these limitations. It comes at a high cost in reference to Peter's presentation, because it requires us to acknowledge the immensity of all that we as a society do not know and to accept the uncertainty and the fear that that brings. It requires ultimately that we all acknowledge that we too could one day join Raimi and Aria in the abyss of ugliness and tell similar stories of similar struggles, wishing to be treated with dignity, respect, and empathy. Thank you very much for listening, and I look forward very much to hearing your questions and your comments.
Yeah, thank you so much, Katharine. This was an excellent way of bringing out the rich layers of disrespect from, which finally attacks oneself, the identity of a person, especially, and you brought it very excellently. And Peter, please, I will go for the feedback. Yeah.
Thank you very much. Yes, I really enjoyed reading your paper, and of course also listening to your presentation right now. I think the paper provides us with paradigm cases of disrespecting patients, of not treating them with respect and dignity. And as you have pointed out, disrespect, by the way, is not a term used by the patients, interestingly enough. Patients seem to talk of feelings of shame they experienced due to the way they were treated, or that the treatment they received was cruel. It was also mentioned in the paper, or alternatively, that they have been treated in a demeaning way, that's the Raimi case, or that they have simply been dismissed. Interestingly enough, almost all of the women you have interviewed have expressed self-doubt and feelings of shame. They were made to believe that they do not live up to certain normative standards, something for which they felt responsible for, and led them to have feelings of shame. I think shame has a lot to do with seeing yourself and not being able to live up to certain normative standards, a normative shortcoming, which is taken as your own fault. And in particular, in these cases, you may believe that it is your own fault. Raimi, that's also interesting, I thought describes the treatment as demeaning. As you put it, it's quote, every single time people continue to treat me in ways that were hurtful and demeaning, end of quote. In this clinical encounter, the problem is not the pain, the problem is the patient, as you also have made clear. And I guess these demeaning ways of being treated are cases where patients are not treated with dignity. So we have the respect, and in particular the violation of dignity case in the Raimi example. Now, I have to say I agree with almost everything you said. There is no space for disagreement, and I agree. You suggested that these forms of treatment can rightly be conceptualized as forms of disrespecting patients. I mean, they have different features. They're also described in different ways, but they seem to be all cases of disrespectful treatment. And I think one needs to ask the question what they have in common to be conceptualized this way. I mean, what turns them into disrespectful treatment? Do they have a common feature? And I was thinking about that. What the essential feature could be of disrespectful treatment. These patients you're talking about, that you interviewed, received. And there might be a point, I don't know whether it's a point of disagreement, but that's a minor critical point. You mentioned it again at the end of your presentation. Your view, but you have to correct me, your view seems to be, with regard to this general issue, what makes these cases of disrespecting patients. Now, your view seems to be that has to do with not acknowledging the limits of medical science, which then leads physicians or doctors to not acknowledging the patient's, for instance, the patient's pain as genuine pain, and giving patients a feeling that they had nothing at all. And it seems to you, on your view, that physicians should acknowledge the limits of their science, acknowledge what they don't know, as you said, and that no objective medical evidence is available in certain situations, which would lead, which would then allow them, put it that way, which would allow them to see the patient's reported pain as genuine pain. Now, should physicians acknowledge that no objective medical evidence is available and acknowledge, therefore, the patient's pain as genuine pain in such cases? Is this what, that's a question I'd like to ask, is this what the respect requirement amounts to, basically? So is it about acknowledging your limits? Now, I'm not so sure about that, because it seems to be correct, and everyone has to agree that in these cases we discuss here, no medical explanation for the pain might be or seem to be available, right? So we agree on that. And there's a quote you write on page 16: objective medical evidence is not forthcoming. As I said, it might be a minor point. And my problem is, I thought when I read that, well, I think it is. Objective medical evidence is forthcoming in these cases, namely the patient's experience, the reported experience, is evidence for their medical condition of being, for instance, in pain. So if that's correct, then respect does not require physicians to acknowledge what they don't know. What is required is rather that they acknowledge the evidence that is provided by the patient's reported experience, to take that as evidence for them being in pain. So there's no object. So I would say this is objective medical evidence. There is no much. You're right. There is no objective medical explanation available. That's a different case. You know, to explain why they are in pain. That's a different matter, and no one might be able to provide us with an explanation. But the evidence seems to be there, namely the reported experience. They say, "I'm, in pain." So the physician who says at one point, that's also one of the examples, oh, it's nothing, does not acknowledge her experience, the patient's experience, as evidence. And I would tend to say that respecting the patient means taking her communication of pain as evidence for having or being in pain. And the physician is clearly disrespectful by not taking the patient's testimony as evidence for being in pain. And in many cases, that's obviously not the case. I mean, it can't be. Because you have no medical explanation, you think there is no medical evidence. So there is nothing there, you have nothing. So there is this idea, and that seems to be the problem, in my view, that seems to be the problem. There's this idea of an objective medical evidence only to be had by her own medical expertise, so only to be had by the medical expertise the medical personnel has access to, right? And given these standards, there is no objective medical evidence. That's the thought. And I think they're wrong about that. There is medical evidence, which is not explainable according to the medical standards, but that doesn't mean that there is no evidence. And the medical evidence, not just the subjective evidence, by the way, I would talk of, well, I don't know whether we disagree on that. I wouldn't say, well, that's just subjective experience or subjective evidence. Probably the doctors tend to talk that way. They say, well, that's the subjective evidence. I would say there's medical evidence, which includes the evidence provided by what the patients communicate. And the patient's experience should be recognized as evidence. I think, well, that's just a proposal, and I'm not sure whether there is an agreement, but I wanted to discuss that. That's the only point, the only probably minor point of disagreement amongst us. I think that this is what treating the patient with respect and dignity might basically amount to. Taking what is called subjective experience as medical evidence. Yeah, that's it. Thank you.
Thank you very much, Peter. That's brilliant points. Really helpful. Thanks.
Do you want to respond to anything or engage with Peter, Katharine?
Yeah, I think that I agree with everything you've said. I think that I've just been finishing up these interviews. I had still got a couple to finish off, but I had the last full interview a couple of weeks ago. And it's quite hard to sort of distract yourself from that and in sort of to develop theories or ways of thinking about it. I guess I'm very conscious that the patients, the people I've spoken to with lived experience, feel that their subjective experience is not medical evidence. So when Sarah Ramey kind of cries and screams and while having this gynecological procedure, it's perceived as evidence of her being a drug addict rather than of her actually being in pain. But yeah, I think that your conceptualization of medical evidence as subjective evidence is really helpful, and yeah, I'll take that forward. Thank you.
And also there is a huge literature and also studies which establishes within the obstetric violence, and then from the point of reproductive field in itself, how women, especially the gendered pain. So, I mean, I could sense that here that it's also women's experiences generally is also questioned constantly. So maybe the idea of gender or the other intersectional factors like economic background or the drug abuse, these are the other things also plays a very important role. And also ethnicity. I mean, I was wondering whether Arya coming from certain ethnic background, I think that can also play a big role when she's interacting with the healthcare system, right? So, I mean, it's a multi-layered aspect the way I would see it is, while of course there's an acknowledgement of medically unexplained, that in itself a big, it's like a Pandora box in itself to open up, right? Mm-hmm. But then there's another layers to that too, from an intersectional point of view. But so the question which I wanted to ask you is, going back to Peter's question, what is a similar pattern which I was also trying to connect? What makes a disrespectful treatment the key crux? And when I was looking at my own earlier works, which is on micro inequities, which I'm trying to capture the understanding of what is disrespect in this a certain vulnerable population, especially the patients who go to the government hospitals or patients from the developing countries when they are interacting with the people in power, right? Is that I feel like there is a constant attack for a self, the idea of a self, like especially within this medically unexplained illness. I think it's about making oneself question yourself is a problematic thing. And whether it's a shaming or humiliation aspects or guilt or making them, I think these are all making oneself question. I think that's the similar pattern, I would say. I mean, if I want to respond, I mean, I think that's where the disrespectful umbrella we can bring together, making one person question themselves when you can also push it back for different reasons. It can be because of I'm a poor person, so I'm always constantly shamed because I'm a poor when you interact with a doctor, or because I'm a women, you are constantly so I think everywhere it's more about questioning myself is where I feel at least the way I want to respond. Would you agree with that, and or do you see it's a different thing?
Yeah, in terms of, I think one thing I was thinking of, especially this week, kind of redrafting my presentation, what exactly does it mean by they use words dismissed, belittled, rejected, but I think that disrespect, as you say, is more of a kind of umbrella. It goes wider than this, absolutely. And certainly the kind of intersectional perspectives was something I wished I could have brought out. Obviously, talking about gynecological pain, I wish there had been space to go into more detail about why this might be, a shameful pain, links between the female body and shame, in particular. And I mean, I'm very aware in the course of my own research, kind of which voices I'm not listening to. That's why I wanted to do the interviews, partly because the memoirs tend to be white, middle class women, affluent people who have the health and wealth to spend a long time writing about their experiences and then seek publication for them. So yeah, I guess I'm very aware of the kind of intersectional perspectives in the voices that I've heard, but also in who I'm not hearing from. I know that, sorry, it's probably not answering your question fully, but yeah, definitely.
Yeah, but I mean, like going back to more of, conceptual question, which again, Peter raises with the idea of disrespect and what makes it a problem in the sense of normative argument. So again, I'm interested in, developing those. So when I listen to your narratives, it's also, I'm like trying to see what becomes a big problem here, why it is a central issue. I mean, of course, when people talk about dignity, it's very clear there is certain large discussions, and I can easily see Arya's narratives is much, we can put it very clearly into dignity issues, right? But then respect and dignity is very intertwined in one way, right? What would you say, Peter, about that? Like respect and dignity concepts.
Well, I think it's as I said, it's the main question to be asked here. What do these different forms of, say, mistreatment, so to speak, what do they have in common, such that we are justified in calling them forms of disrespecting patients? And I think not treating someone with dignity is also a form of disrespect, and probably a special form of disrespect. And I thought what all these things have in common is that, you know, the patients, the testimony is not taken seriously, right? So they're either put down, that's the demeaning case, and that has to do with dignity, or they're simply ignored. But what they have in common is they don't count. You know, they're not taken. They don't have a say. But it's not a say. They're not taken as evidence provider, right? So there must be something wrong with you, right? There must be. It's called misinterpretation. Is one word used by Katharine in your paper. There's you must get it wrong. I mean, you simply have nothing, and so that's why I think it's probably it's about taking your experience. I mean, the way you express and report your experience taken seriously as evidence,
Yeah.
and I guess as you are in pain, and it's obviously otherwise you would be a liar. But given that you're not lying, you are in pain due to the fact that that's how you feel, and that's what you're telling us, and so what these cases have in common, all these cases that people have been dismissed, not been taken seriously, and of course to probably also reasons, as you mentioned, I mean, ethnicity might play a role, gender might play a role. I mean, this fits in somehow in this whole debate about epistemic injustice, right?
Yeah.
I thought, you know, and of course, epistemic injustice is an injustice not experienced by all people in the same way. For instance, you know, I mean, it's standard cliche, but white men might be privileged with regard. I don't know whether you confirm that, Katharine, but I guess certain groups are less privileged, and other groups are privileged with regard to this kind of epistemic justice. And this is a case of epistemic justice, which is probably the core of the disrespect the patients here experience. And no wonder it's mainly about women. You know, it's the cases I take it as mainly, you know, you talk about your interviewed women, and they also, as I said, probably you might get a different story if a man says, well, you know, I'm in pain, and it's hurtful. I guess the reaction will be different.
Yeah, and also it's quite an ontological and both epistemological issue with medicine itself, like how evidence-based is so much of a push, and this medical, it's a challenging, it's uncertainty, as Katharine clearly played out, right? I mean, when there is an uncertain and the medicine can't handle it, and then when the patients are also trying to explain and trying to show they do have a pain, so there is a constant like to push back, like, no, it doesn't exist. So it's like they want certainty. I think that's another push way, of course. So we have a question from Kalpa. The gender and racial bias in research may be that the medical professionals do not have the knowledge. Katharine, do you want to respond to that?
Yeah, I think, I agree. I think there's also that lack of acknowledgement, as I said, I mean, about this lack of knowledge, which especially you see in cases of so-called medically unexplained illness, that there's this idea that things have been researched exhaustively, and that's why we haven't found it. But actually, you know, if you take ME, CFS, I think in most years in the NIH it's been given less funding than male pattern baldness, less funding than hay fever. So there's no wonder that we haven't found it, which again I think comes back to this inability to accept the limits of our knowledge, I think. But yeah, absolutely, gender and racial bias. I think it's one of the reasons that I'm looking at women's experiences, not only because of theory and writing on women's experiences of shame, but also on, I mean, women are disproportionately affected by these conditions that I'm looking at. So yeah, absolutely. I think that's no coincidence that women are disproportionately affected by conditions that are considered to be medically unexplained.
Of course.
Sorry, good catch.
Do we have any questions, or we can even keep engaging further? The floor is open for all the questions. No. I definitely agree with Kalpa. Yeah.
If I may. Yeah, there seems to be, I don't know, maybe a deeper problem that we care to admit at the level of medical education, which goes even further than what I was saying before. Something about, yeah, the medical evidence and the fact that medicine now seems to be only based on, well, evidence-based medicine, and so on clinical trials and of the results of clinical trials. There seems to be the attitude that what comes out of the medical trials, these are the only references that we can take. And then if the patient comes in and says, I have these sets of signs and symptoms that are not included within the description of whatever treatment or illness or disease, then it's dismissed automatically. I really do not understand why this is the case. And I'm wondering whether it's the case of a medical culture that should be challenged, you know, from the very beginning, you know, from the first year of medical school, basically. And maybe more ethnographic studies ought to be done at, you know, within medical schools. I don't know. What do you think?
I think somewhere, at least personally, though, I mean, this is an interesting question for me because medicine is part of the institution, like the larger society, right? So, and then I'm like wondering whether the patriarchy has bigger role in here into play this, into the way the women's bodies are conceived, or the pain is the way it is understood generally, because the pain is something much more of, I mean, does it have a masculine or feminine characteristics? I mean, how people dismiss pain. I mean, so I'm like thinking whether patriarchy has something bigger role into understanding medicine as a culture. I mean, I would see it as yes, but I'm curious now what Peter and Katharine has to say too.
By the way, just the question is, Katharine, you only interviewed women. Is that do you intend to extend the interviews, whether there's similar experiences are made by men or with regard to the different ethnicities? That would be interesting. First of all, I mean, is it only an experience shared by women? What is your hunch? You think that's the case? Men are not target person for this kind of experience?
I think men definitely are targets. I've had a fair amount of criticism from men with some of these conditions, which I think is valid. My argument was that, I mean, it's a 3-year project. There's limits. I'm also comparing the literary and the qualitative accounts, and quite frankly, enough men have not written about their experiences. So it was not just this theorization of shame and female experience and the link between the female body and shame, but it was also the fact that it's purely practical. I mean, there's been very few accounts written by men. So, however, and I did receive one comment by someone who I had worked with previously. My project is a result of a lot of engagement with with people with lived experience, especially with ME. And one person said to me something along the lines of, oh, I hadn't realized it was my illness was not only a shame-inducing experience, but it was a shame-inducing feminizing experience. So in other words, that my research had made his experience to be a shame-inducing women's experience, which was not my intention at all, and certainly gave me pause for thought. But yeah, absolutely, I would be very interested to look at people who identify as men's experience, and I think I would have a sample of people to look at already. And I wonder if these people would experience shame in different ways, perhaps because of the idea that maybe they wouldn't, but I guess there is this idea that more women are affected by these conditions, and therefore it's feminizing in a way. That certainly was the impression I got from people who spoke to me. But yeah, it would be very interesting.
Yeah, I mean, this is would be certainly very fascinating to think through. And then also, like I mean, this is also like widely accepted notion, right? Even within academia and also within a general understanding that men hesitate to talk about experiences, like especially. So that's again goes back to the idea of emotional vulnerability, how much men want to do that and with whom. For example, I mean, most of my interviews when I go for as a qualitative researcher, women are much more open and share very clearly the experiences and the, you know, very in detail richness which we get from as a qualitative researcher. Whereas when I go with most men, there is a very cut off details, like, it's just this happened. So I'm like also curious, like who does what kind of voices which comes through when we talk about certain experiences, like whether it's a shame or humiliating experiences, and who. Yeah, that's definitely a very interesting project, but I get it. As a researcher, we don't have much funding to do everything. Yeah.
But I think also, I mean, that's interesting. Can I just, right? Yeah. I think it's also in need of an explanation. Why are men not talking about his experiences? And probably it would be even more demeaning and more humiliating for men, probably, if they were victims of that kind of treatment, I guess. So there is a reason why they say don't talk about it less than women, because they would take it. I mean, not all of them, but a lot of them would take it as demeaning in a way that is, not open to that. You shouldn't open up on that kind of humiliation.
Yeah. Somehow my theory, I mean, not theory, I think it's quite of, at least feminist circles, they say it's because the way the socialization of men and women, I think that has a lot to give into this. But we have a question or a comment, I guess, by Abhi. Do you want to comment on this, Katharine?
Yeah, I'm just going to read the comment. Yeah, thinking about the role of public and patient involvement and how these practices or not of respect and these activities have potential. Yeah, absolutely. And it's something that I've tried to do in my current project. And I haven't done it perfectly, but I have gained a lot of benefit from that, and something that I'll take forward if I'm fortunate enough to do another project, to make engaged research even more of a key part, an essential part, right from the outset. I think it's not necessarily, it is about respecting people with lived experience, but I think also I've seen it's about getting the right results. Like I said, my project comes from a lot of engagement and activism, patient communities, and I've seen what happens when people don't talk to people with lived experience and they reach the wrong conclusions. The nice guidance that I mentioned for ME/CFS, these trials were degraded using the grade methodology from good evidence was the previous guidance to very low or low quality evidence, and these were trials, large clinical trials, which it doesn't seem used any patient experience other than for these subjective measures. But I think it comes back to whose voices are we listening to, who has the right to give evidence. And certainly, if I might mention the nice guidance, which is a recent update, it's been quite important to my research, but it was changed because of I guess different forms of evidence and how we consider evidence and how we grade that evidence. And there was absolute outrage. The Royal Colleges have refused to implement this guidance for some of the Royal Colleges for this guidance for ME/CFS because they deem it as activism and not research. This drawing this difference between activism and research, i.e. people who have lived experience, that's not evidence. It's really quite stark seeing those conversations go on and seeing how far we still have to go actually to put patient and public involvement right at the centre of research projects. Not just in the medical humanities, but in more generally. I think that's a real, I thought we were further on than that personally. But yeah, sorry, I'll stop and see if anyone else wants to comment.
Any more questions? Yeah, please, Maria.
That's actually really interesting because in my research, I'm doing oral history interviews. And still today, there are many who refuse to take the interviewee's experiences as evidence of historical events or historical circumstances. So I guess, epistemologically speaking, there's this problem that touches upon every field of research. By the way, I'm researching within health. So I'm researching global health and policy and how it plays out at local level in Italy, especially. And the oral history interviews I'm asking questions about childhood illnesses, so people's experiences, you know, especially elderly people. And so it's really interesting how I can see their experiences, and already imagining how maybe the medical establishment might not take their word as something to be seriously heard because of this. So it's a double thing, you know, it's an oral history interview, so historically speaking, maybe not so valid according to some people, and also because they're talking about health issues, and you know, even then it's their own experience, so not so valid. So yeah, I think there's still a lot of work to be done on, you know, the epistemological acceptance of these kinds of evidence. Yeah.
No, that's definitely true. I mean, it's a struggle for qualitative researcher to be in the field of generally in health research. I mean, and especially to get these views on forefront. That's true. Yeah. Yeah. Is there any other questions? We do have a comment from Kalpa. Yeah, that's true. Yeah.
Yeah, very much.
Is there anything anyone wants to talk or have a comment or question? We have another 10 minutes more, or if you're all saturated and go for the weekend, then of course we can wrap it up too. Peter, do you have anything particular? I was trying to
no, sorry. Yeah, sorry.
Now I'm
Go ahead.
Connect your presentation. I mean, I'm not sure whether now I can do it, but maybe we do have some time. So I was thinking, like, when you did present your argument, right, that you would consider to have a minimalistic understanding of respect for autonomy. Did I get it right? Like consideration, respect, or would you go for the understanding of respect for patient's will, but the subjective experience? I remember you said yes, we should consider the subjective experience, but then we need to have a good reasons for it. You did put that as a condition, but did I get it right? I mean,
No. My view was actually I wanted to come back to this point. I think the subjective experience is to be taken as evidence, and then also what follows from that, it is definitely to be taken as reason giving with regard to treatment. There's no doubt about that, and that follows exactly, and providing with strong reasons.
Okay.
Even as I said, I mean, in the case I had this case where it might be difficult for the doctor to share the patient's view, and it still has to accept her view as reason giving, and that's probably a case of such a difficulty, difficulty of understanding, or sharing. Probably understanding is better. That's an example. The example we discussed, Katharine's paper is discussing, where there is a difficulty. Obviously, they say, well, we can't see anything, we can't explain it, we can't see anything. But that would be a case definitely of consideration, respect, probably even more than consideration, respect, and opening up to this kind of it is not respecting the will. I was talking about respecting the wishes and the will. Here it's first of all taking seriously the experience as evidence. So that's the first step, definitely. And I would definitely be very much in favor of taking this seriously. So that's the answer.
Thank you for clarifying, Peter. Yeah, it was helpful. And Maria, please.
Thank you. I had actually a question for Katharine. You mentioned at the beginning of your presentation something about the academic definition of respect and how it in fact contrasts with that of your interviewees. In what way, if I may ask?
That's a tough question. There was over the summer when I was preparing this abstract, which then became this presentation. I think when I came back to it, I then didn't want to get bogged down in other definitions. I wanted to just focus on what these people thought. So I couldn't really tell you, I'm afraid. I perhaps might pass that to Peter. I don't know if you had any thoughts about how my presentation differentiated from academic definitions. This is a really good question.
But I think it is, as I said, your paper provides us with excellent examples of disrespecting patients, and probably not disrespecting their autonomy. Probably these are not cases of disrespecting their autonomy, but disrespecting something else. I mean, just there are different forms of disrespecting people. One is to disrespect their autonomy. But we're not just autonomous persons. We're also persons with people being in pain. We also have a body. We're embodied beings, and I think the object of disrespect in your cases, and I think it's excellent, and I learned a lot. The object of the disrespect is different and has to do with what we were just talking about. So I would say it is adding a new aspect to this discussion about disrespect or respect. These two things go together, of course. I was focusing autonomy. I don't think that the problem here is. I mean, the problem in your case has rather to do with for instance, dignity than autonomy. I mean, demeaning is nothing. I mean, for instance, to be treated in a demeaning way is nothing special about. It's not say a core feature of not being treated as an autonomous person. I rather think it has to do with not being treated as a person who has dignity. Right. So yeah.
Yeah, I mean, to respond to that question, I think the way since I come from within the bioethics discipline, I mean, which is dominantly, they do talk about respect for autonomy when they talk about respecting, but I think we need to have a re-understanding of the whole understanding. It should be embodied concept, especially in these situations, which Katharine was talking about, our earlier sessions by Vania, which we referred to our humiliation aspects, it's more about the concepts which hits upon. I mean, if I want to talk about from an ethical principle of respect for persons, I think and it should be much broader sense, not just choices and actions of decision making, but much more beyond it. So which for me, what is beyond is an embodied concept. I mean, that's what I'm trying to work towards. And I think that's much more fitting, right, to talk about respect for persons. Of course, dignity plays a role, but dignity is something much more in a higher level. But in a everyday interactions, I think respect for person is something which is by default, but it can be also embodied. You can practice it. I think that's where we can talk, I feel, is much more a good concept to engage in these discussions. At least it's a way I would see it as. Yeah,
I fully agree, and it's respect for persons, and respect for persons is just respect for their autonomy. It's more than that. I definitely agree.
That's true. And we have, okay. So okay. Any more the last burning questions or comments or yeah. Okay, so I think we can wrap it up, and this was pretty excellent, Peter. Thank you so much for your talk and for giving the feedback for Katharine, and then for the rich discussion for all the participants here. And Katharine, thank you so much for insightful, lived experience of sharing these to clearly bring out what are the issues with disrespect and understanding of these issues, which is central to the workshop too, of course. So thank you so much for everyone, and hope you all have a nice weekend. Thank you.
Thank you very much, Supriya, for organizing this. It's absolutely wonderful event. Thanks very much.
Thank you, Peter. Thank you. Thank you, Katharine.
Bye.
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 Bye. Thank you.